and I want to thank you for joining us today. I am the director of the Center for Health Workforce at George Mason University, and this presentation is being hosted by the Wean Foundation, and I want to thank them for allowing us to come together today to discuss this really important topic. And again, joined with me is our panelists, and I'd like to introduce them one by one. And with us today, we have Christina Dumas, who is the AmeriCorps Program Officer for the Virginia Service Commission here in Virginia. We have Sandra Cerna, who is the Director of Health Equity for the Virginia Department of Health. We have Janusz Wojciechowski, who is a professor in the Health Administration and Policy at George Mason University. And we have Dr. Rebecca Sutter, who's a professor in the School of Nursing at George Mason University, as well as the Wean Foundation's co-founder and president, Sri Vasareddy. So again, our topic today is one of much importance, and it is a population that we need to be prioritizing in the ways that we support, both through direct provision of care, but also through the ways that technology can help support this population. So as we continue to face the challenges with substance use and opioid use disorder, community care providers can play a critical role in the effective screening and provide linkages to care for patients that struggle with substance use and opioid use disorder. In many communities, treatment systems lack the ability to remain in contact with our individuals and our patients who are struggling with SUD or OUD. And technology has the potential to improve that connectivity and allow us to better care for that foundation, for that population. To start us off, I'd like to ask Dr. Rebecca Sutter to lay a foundation of what the struggles are and the challenges that persons with substance use disorder and opioid use disorder are currently facing. So Dr. Sutter?
Yeah, so I think it's first of all, thanks for having me today. I think it's really foundation to the work that I've been doing for many years now in partnership with many of the other presenters here today. But I think it's important to understand how we got here, first of all. And I think that there's been really three distinct waves of this opioid epidemic and these opioid overdoses. And it really begins back in the 1990s with some real prescription, and we were overprescribing of opioids. And I think that we've really led down that track of overdoses starting in 1999 when we saw kind of increasing data telling us that something was going on. And then from 1999 to about 2010, we saw there some notifications that there was some prescribing issues that were going on. We saw that we were starting to withdraw some of that overprescribing in response to the overdose rates that we were seeing. But we also at the same time saw, as we were withdrawing legal access to prescriptions, we were seeing heroin increases. So by 2010, we were then seeing a transition from being a prescription opioid overdose issue to a heroin opioid issue. And then by 2013, we saw the synthetic opioid coming into our communities. And in 2017, after the trends were really increasing, there was a public health emergency that was declared by the Health and Human Services in the United States that we had a problem. So I think it's important to understand how we got here and that we've had these three phases of it, from prescriptions to heroin, which was a more traditional opioid history, to now we're really in a synthetic opioid crisis. And what we're seeing is that the fentanyl is now not just in its traditional forms of powder, but that it's certainly also put into other ways of being distributed, inclusive of that being in marijuana, certainly integrated within cocaine use. And so the fentanyl is across all spectrums of substances at this point. And so we had some hope that in 2018-19, some of our data was telling us that we were having some flattening of that opioid overdose crisis. Unfortunately, that was probably representative of the COVID-19. And in 2020 and 2021, and now as we are looking at the data in 2022, we're seeing huge spikes in our overdose rates. Sadly, we're also seeing that the populations where it's traditionally been seen, which is traditionally in our Caucasian male population, about 70% historically from an opioid overdose perspective have been white males. We are seeing that diversify, and I'm hoping that we're going to be able to get better data to drill down. And I think that's one of our interventions that has to happen, is get the right data to really show what's happening. But we're also seeing a younger and younger population that is being as having opioid use disorder and severe opioid use disorder, inclusive of fentanyl. We're seeing some targeting of that population by drug distributions across, so that again, that marijuana laced fentanyl, there is some intentionality in getting fentanyl addiction to our younger populations. So I think it's important to understand that. I think that historically, we've also seen siloed care, and we have had mental health and substance use disorder in its own siloed funding sources, in its own siloed treatments. And what we know is that these populations cross all sectors, and they certainly cross across systems, inclusive of Department of Social Services, inclusive of course, our mental health providers, inclusive of our criminal justice system. And so our criminal justice system has staggering numbers that are becoming the treatment for those with substance and opioid use disorder. And until we are looking at how we can intersect these sectors of support, those are going to be our best chance for interventions. Like I said before, and then I'll move on to the next question, is because the population is becoming younger and younger that we're seeing with opioid use disorder, our school systems now need to become part of the conversation and part of the interventions and part of the way that we serve and get on top of those that need us in our communities.
Thank you. Can you speak briefly on the stigma that has been surrounding this population and how we break down some of those barriers as it relates to stigma?
Yeah, absolutely. So very similar to what we see on stigma as it relates to mental and behavioral health. The same stigma is there around about substance use, and specifically opioid use disorder for this conversation being a behavioral, and it's part of poor decision making. And what we know specifically about opioid use disorder is that opioid use actually leads to changes and physiological changes in the brain. And so when we're changing the physiology of the brain, we certainly need to treat this as a chronic disease, and we need to think about this outside of simply being a choice, a decision, or a behavior, and putting interventions in place that address that, and providing services. One of the best chances that we have to get on top of opioid use disorder is the utilization of medication for opioid use disorder. Historically, those are methadone, Suboxone, which is really buprenorphine, and naltrexone. That is the evidence-based best way that we can get opioid use disorder as a disease and give the best chance for long-term recovery. So stigma, also, we need to relook at the data, right? We need to relook at the data of who this is affecting. We need to have targeted communications that are effective for that. We need to break down the cultural stigmas. And I can relate that significantly to what we're also seeing on the ground, which is really an increase in the Hispanic populations and the Latino populations that we're seeing that are actually showing up for treatment, and that are actually starting to have the conversations. That's a huge win when we can say that we're able to kind of infuse there, where traditionally mental health and substance use is more challenging to communicate with the Black and Brown communities that we serve. So we've known for a while that we have some real need to get the right data. We know that we've had the real need to get the communication right and make it culturally appropriate, and to work really hard on the stigma reduction across in order to provide equitable access and equitable long-term outcome for these populations.
Thank you. And I think that leads us to the next really important question, and that's for Sandra. Can you talk a little bit about, Dr. Sutter spoke about data a lot and how we use the data to inform kind of decision making. Can you talk about why it's important for data as it relates to equity and how we use data to support that?
Absolutely, Caroline. So, it's important to consider the variety of populations that are impacted by many of the health issues, including the one we're discussing here today. And, you know, the great work that has just recently been described really was, you know, some of the foundation of that was leveraging data tools that looked at pockets across, you know, the state of Virginia where you're really seeing a dearth of opportunities for Virginians to be healthy. So, you know, I sit within the Virginia Department of Health, the Office of Health Equity. Within that, we have a division of social epidemiology, and they essentially created a tool called the Virginia Health Opportunity Index. It's actually currently being undergone for an overhaul and will be updated and released for early next year. But essentially, the key part of the Opportunity Index is it looks at a variety of factors outside of just disease and impairment, but what are the economic conditions like job opportunity, rates of poverty, educational attainment, transportation, all of the factors that, you know, play into what we know as the social determinants of health and can make folks shed light, not make folks, but shed light on what folks are dealing with in their day-to-day lives. And you know, if you're dealing with job loss and you know, can't find a job for a long time, and of course that influences your income, but it could also lead to depression and anxiety, which we know that impacts the body in a variety of ways, triggers a stress response. And if a person may not have, you know, the appropriate social support or whatever it is, you know, they may turn to substances like opioids to alleviate some of that tension and that stress, right? And then before they realize it, they're addicted. So having the data to realize what are the community conditions, where are the neighborhoods and the communities that would really benefit having an infusion of programs that support people and you know, make sure we're combating these addictions and having a whole person approach. That's really critical. I think the other thing I'll speak to, and sometimes it's challenging because and I'm talking about the, you know, the big data in terms of disease rates of addiction, along with these poverty rates. Usually that's gathered at the federal level. And depending on the quality of data you have, sometimes you can't drill down to the zip code or census tract neighborhood level. That can be really challenging, but it is important because what you often find when you are able to do that is in, you know, counties like Loudoun County in the state of Virginia, you know, across the board, if you look at another data tool like the County Health Rankings tool from the Robert Wood Johnson Foundation, you'll find that Loudoun County looks like it has lots of opportunity for folks, and you know, the average, you know, median salary is extremely high compared to the rest of Virginia. But when you drill down, you realize that there are neighborhoods and communities within the county where that's not the case for everyone, right? There's folks that are suffering from poverty and suffering from other issues that need to be a concern. So when you get to drill down, that's critically important. I think the other thing I'll say as far as leveraging data for equity, a big piece of that is also qualitative data. So the data that you get from the communities that you're serving when you're going out, and it supplements the information and the story that's being told with, you know, the big national or state data set that you may have where it's the disease rate, but it puts a person and a face to the populations we're talking about, and they have the lived experience that explain, you know, what they're dealing with, what they're struggling with, what could be more effective? How can their community and social service providers and health departments and others work together and serve them more effectively? So we have to have that perspective as well. And I think that's critically important when we think of data and think of equity and making sure their voices are included.
I think that's really important as well. And I think that's a good segue into the next question for Dr. Wojtaszek. And that is, Sandra was able to really articulate the importance of the use of data, but why, and having the right data at the right time for the right people is very important, especially if you're looking to have equitable access and care. How does technology play a part, and how can we use technology to support that concept?
Okay, so let me start with saying that I'm a great believer in technology, right? I think lots of problems can be solved with technology, and lots of problems can be solved with right data. We just need to get that right data, right? The problems really start with people. People need to realize that they should share their data. They should understand what it means that they use technology, where the data actually goes, right? There is a really big problem, people are afraid of data that goes anywhere near government, right? They don't want to share this type of data, and they don't realize that, all of us are being tracked by our cell phones, and our cell phone company and whoever actually built the apps on those actually know what they do, what we do, and everything else, right? So on the other hand, there is this problem that we don't want to share data with the government because we're afraid of something, right? So if people are educated, people understand, and people understand that those apps can help, right? It can be a cell phone app that, helps person who is addicted and do it all the time, monitors all the time what's going on, where you are, what are you doing, and actually sends you a reminder at the right time, you're in this situation that is dangerous, do something else, right? And that can be done by technology real time. And that app at the same time can collect data about the behaviors, about what person is doing. And that data on aggregate level can help decision makers, can help researchers, can help public health departments find out what is really going in the population. So there is a great need of educating the end users, the people with the technology, so they're not afraid to share their data. Well, sometimes they should be afraid of sharing their data, but obviously, they need to know, they need to understand that the technology is there to help them. Mm-hmm. The same applies on the other side. The decision makers, those that analyze data, need to understand data, need to understand technology. We can do lots of good with the data, but we can do lots of bad with the data, right? And going back to the previous speakers, we can do a lot with data, but there is no perfect data set. As a person who analyzes data, we know that the perfect data set doesn't exist. We'd like to build one, but it's not going to happen. Why? Because there is the way the world is, and there is the way that we can observe to the data. And these are two different things. We observe the data, and we think we observe the world. We build models, we make predictions, we make decisions based on the data, and we assume this is what's happening in the real world. It's not necessarily the same thing. So the decision makers need to understand data. They need to understand the limitations of the data, which is even more important. That the fact that we observe something in the data, it's not necessarily that this is the thing which is really happening. And what's the relationship between what people do, what's the real life, what we see in the data, the decisions we make, and how we impact and then evaluate those decisions. Decision makers need to understand. Now, again, I'm a great believer in technology, and a great believer in education of the technology. And I think every decision maker, everybody, everywhere, should be data programmer and data analyst and understand everything. That's absolutely impossible, right? So we go back to the problem of how do we train people in doing it, right? And here at George Mason University, specifically in health informatics program, we are actually in the business of training people to be data analysts. But not pure data scientists, but those that understand the problems on the ground. They understand population, they understand health issues, and they also have the skills to analyze this data and provide right data and right conclusions from that data to decision makers who can actually work on it. And without those right people, decision makers can't trust this data, right? It's everybody, it's the same. Yeah, we like to see all the data, but then, we still do our own thing because we don't trust what the data actually tells us, right? So there needs to be trust in the data, but it requires right people actually to do the right things. The last point I want to make is the data in public health, right? We were talking specifically about, the substance abuse and an opioid epidemic, but there is this thinking that the data is useful in emergencies, right? We have opioid emergency, there was a COVID emergency, there are others, and then, everybody jumps on data. We try to make decisions based on the data, which is incomplete, which is not there, and so on. But it's not about emergencies. When you look at public health, it's about this day-to-day data collection. It's day-to-day understanding what's going on in the population and day-to-day improvement of the health in the population based on the data that we collect. So it's not about those things that are happening right now, but thinking way ahead in the future, being able to collect right data, because public health is something which will exist forever.
Yeah, and I agree.
Carrie, do you mind if I just jump in there real quick? It reminded me of something there when it was around, we know that about 66% of people that have experienced overdose had at least one potential intercept point for an intervention that would have prevented that overdose. And I think those spaces are EMS responses, a school nurse, a teacher, other areas of the systems that would have, if they were connected and combined, been able to identify, a potential overdose risk and a potential overdose. So the idea around really having a true understanding about what's happening on the ground, what the day-to-day lives of people are, where they are, and getting that bi-directional feedback from them that then feeds the larger data systems for decision making, I think is vitally important. Would you agree on that?
So, but that requires right technology, right? So one thing is to provide information to right people at the right time. And, it could be EMS, it could be somewhere else, but every person collects humongous amounts of data every day, right? And if we on top of this, when we put wearable devices, we put stuff which is collected by smartphones, by smartwatches, but all of those devices, right? This information potentially can flag somebody or can raise this flag that something's going on. But there's no single person that can look at this data, analyze it, which is why we're building all those technologies which people refer to as AI right now, artificial intelligence. And those are the smart algorithms that are methods that can sift through that humongous amounts of data and discover something's going on and then make a decision that somebody needs to be informed about this. Right. And we can talk about this from two perspectives, because one thing can be, let somebody in EMS know that the person is, at risk. But the other can be the technology itself can provide the intervention. It can be a really smart app on the phone that will send you a reminder, you're getting in the wrong neighborhood, you'd better actually go home. Right. And, these are reasonably simple solutions that can be done by technology, by informing right people. We just need to be able to do it.
And I think that, we've touched on a little bit of kind of the possible solution pathways. And I think we'll extend on that a little bit. But I wanted to start with those of us that have spent their careers in education recognize that the future workforce needs to better understand some of the things that we've discussed here today. And one of those opportunities that has been presented, I'm going to ask Christina to speak about, is the AmeriCorps program. And the AmeriCorps and the way that they have expanded for public health AmeriCorps. And after COVID, we recognized that we didn't have a health workforce that was able to use technology, to use data, to collaborate effectively together. And I think the movement towards educating our future workers to be a little bit more aware of the importance of technology and data is priority. Christina, can you speak a little bit about one of the strategies with AmeriCorps being expanded to public health?
Yes. Thank you so much for having me. As Dr. Sutter said, I'm an AmeriCorps Program Officer at the Virginia Service Commission. So just briefly, AmeriCorps is the federal agency that engages Americans in service through stipended volunteer work programs. So Public Health AmeriCorps is a unique partnership between the CDC and AmeriCorps, and it has two main goals: to meet public health needs in historically and currently underserved communities, and also to provide pathways to good quality public health careers by recruiting members who reflect the communities in which they are serving. So sort of the overarching goal is that the next generation of public health leaders that Dr. Sutter was mentioning, we focused on equitable health outcomes for those communities and will be representative of the diverse communities that they're serving. And that also, hopefully, they'll be service-minded leaders who will be inspiring others to serve or volunteer and possibly to pursue public health careers in the future. So that's sort of Public Health AmeriCorps in a nutshell.
Thank you. And Dr. Washusek and Dr. Sutter, as you kind of lead the efforts in our region with the Public Health AmeriCorps, can you talk a little bit about some of the strategies like we've just discussed previously, and how you're infusing that to make that future health workforce a little bit more aware of data technology and the needs to use them effectively?
Yeah, I'll start, and then Dr. Yanush, why don't you just pipe in when you can? So we really believe that the next generation, again, really has to have a firm understanding about the combination between what's happening on the ground, what's happening in the communities, what's happening at an organizational and an individual level, and how that actually looks on the data side, and how you can actually merge those two. So we do have a cohort of the first Public Health AmeriCorps that are going through, and they are working in what we have really looked at as a learning laboratory within our own Mason and Partners clinics, which serve the most vulnerable across the Northern Virginia communities, and understanding what it looks like at this organizational level, to understand our clinical flows, to understand where the data comes in, to look at the complexities across social determinants, to look at the complexities across populations and individualized populations, to have a deep understanding about how that data actually gets there. And then also on the other side, really understanding what the power of data is, and to get the right data sets there so that you can actually have usable data. And in our case, really with a deep understanding of data visualization that really can help in the decision-making side of it. So we're creating an environment of learning, and then an environment where they will go into the communities and be able, after having experience of that, and going into other organizations and being able to also help those community organizations who traditionally have challenges with data management, and therefore those data sets are not part of the decision making that's there. So to infuse them in there, we know that many of our best nonprofits and our best organizations that are serving in the community hold on to data in spreadsheets, and they hold on to data in different ways, but those small data sets are never fed in for decision making. So really teaching our students and our AmeriCorps members to go into these organizations, help those organizations to construct the right data management for them to be able to be making the right decisions, and combining those data sets for a more holistic look into what's happening in that community, outside of just the large data sets, but the individualized level data sets. We think that really is going to improve the equitable lens that we can have on communities and populations.
And you spoke previously about the population with substance use and opioid use disorder, and how some of the technology, we can teach our future workforce to use technology to support those connections back to providers or access to care. Can you talk a little bit about how specifically for this population you will train using data and technology?
Right. So some of those technology enhanced care, I like to term it, is that we need to be able to understand how to help this population, but we need to have that bi-directional feed as to what's happening at that time and what intervention is going to be most responsive to them. So I think that Sandra, you talked a lot about creating the systems for them or with them instead of for them, and really having them be part of that kind of construction. I think for many times we have created models and designs and systems that say, we're going to overlay this because we think we know best, right? Let us overlay this onto this. And I think the opioid epidemic has certainly proved us wrong, and that we've created what we thought were the right pathways. But the truth is that we need to be inclusive of those that need to access those solutions and those interventions in making the right decisions. And so how can we have them utilize technology so that they are giving us the bidirectional feedback to improve our interventions, to improve our systems, while at the same time, being able to give them the needed care that they need. So I think that using technology, in my opinion, for opioid use disorder is really that bidirectional communication linkages that we can get to do the kind of this rapid quality improvement as to what we're seeing, the responses come back. What are they responding to, so that we can really build a robust technology platform that they can then receive the care for.
And Sandra or Dr. Sutter, can you just give an example of how technology could be better utilized for substance use and opioid use disorder patients? How would you use technology for the population?
Do you want me to take that, or you want to take it?
I think you should go ahead and take it
Okay.
with your expertise.
So just looking at, we know that in substance use and opioid use disorder, that really there's a real push around really retailoring people in their lives, places in their lives, and things that can trigger, a setback or a relapse. I tend to use the word setback instead of relapse, because I do think that that's part of the trajectory of recovery. Is there GPS mapping? I know, she brought some of that up. Like, are they entering an area that they have had historical use? Are they around, are we seeing elevations when they're around certain individuals that they have a history of use with? Are we seeing some increased signs of increased heart rates? Are we seeing some increased anxiety? And can we give them a trigger that says, you are entering a neighborhood? I think you brought that up. Your heart rate is being responsive, that you're having some sort of increased anxiety. Can you step back from the environment that you're in? Can we do a reset? Can we do an intervention where you're doing a fast walk, so you're getting your heart rate up, and we can help you to de-escalate more rapidly? So that would be the people thing. And then the things, then kind of being able to capture in a moment's time something on an app that says, this thing has triggered me. For some of them, it's sometimes where on the desk, or it's a piece of clothing that they've historically worn during use. How can we get them to identify, this needs to be removed because it's triggering me? And so they need to be able to have, real time kind of ability to get that. They need that reassurance that comes back. They need that ability to say, I'm in crisis. I need intervention now. How can I connect to a peer recovery support specialist in my community that can connect quickly with me, so that I can actually kind of work through and not have a setback and not have a relapse? That is actually a huge harm reduction strategy, how technology can use. And I can tell you that those kind of interventions, and just working at individual levels and working with those opioid use disorder for a really long period of time, they need to have that kind of rapid influx of information to keep them kind of moving in that trajectory. I also think that we know with substance and opioid use disorder that it changes their ability to have executive functioning. And what that really means is that as people are really going on the path of longer term recovery, so they're outside of kind of acute recoveries, or in those first year, and they're now in their second and third year, they've still had, like I said before, brain changes. And it changes the way that they can use executive functioning and around scheduling. So if you can't have an ability to really get a schedule or a timeline or put things in place, then how you really do struggle with getting into jobs and employment and staying employed and doing those things. So how can we use technology in the short term for harm reduction on overdose? And how can we use technology long-term reassimilation into kind of those social determinants, like Sandra talked about, making sure that their job is secure, making sure they're able to show up at appointments to get the services that they need. How can technology enhance that aspect of it as well?
And I'd like to give Dr. Youngerson an opportunity to respond. What are the limitations to having this technology in place currently?
Okay, so first point is that technology is very personal, right? I may like one app and somebody may like different app for doing the same. You know, one person will like, you know, to get a text message. The other person will like, you know, a smartphone or a smartwatch, which is doing something. You know, one person likes to talk to a real person on the phone. The other feels much more comfortable interacting with a chatbot and you know, being this AI thing behind. So it's a very personal thing. And when we think about all those technology-based interventions, we need to think about how to tailor them to specific individuals, to specific people. We also need to think how we measure, evaluate, and how do we know those solutions actually work. They're very, very personal, right? If you look at traditional types of intervention, what you may see that, you know, most of the people that use specific app that was built for, you know, monitoring substance abuse, just delete the app or stop using it. But there is this small portion of people that it works perfectly. This is exactly what they want. And, you know, it's the greatest thing that ever happened to them. You know, so what that 90% of people delete the app, you know, for the remaining 10% is the greatest thing. And they actually stopped using it because of that app, right? And I think it's actually a great success, right? And the other 90% may be using different type of technology, which is one that they actually like. Right. So we need to think about when we go back to data collection, when we go back to how we monitor those things, how we think about the technology, we have to think, how do we measure success? And, you know, honestly, if I build an app that helps just one person, you know, it's already great success, right? Even though it failed for thousands of other people. So we need to think how to measure it, but we also need to think from the perspective that this is something very, very personal. And everybody needs a different solution, you know, how to fight their addiction.
I think you just answered the question too, is that we've built systems for people and we need to have a way to get bi-directional feedback back to us so we can improve it so it is more responsive for people, right? And so they need to be part of the design of the systems and the technology use that we have as to how they're going to respond to it. I think that was a prime example.
And I'm going to turn this back to Sandra, because one of the things that we know happens with the use of technology is that there are barriers to access to technology. So when you look at equitable access to things that do enhance or potentially improve health outcomes, how do we address that from a system to make these things that we know potentially can influence recovery available to those who need it?
Sure. I mean, I think, you know, one thing that I keep in mind, because within the Office of Health Equity, we have the State Office of Rural Health. And, you know, certainly access to broadband as a whole is not limited. It's not an issue just limited to rural health areas. You know, we are well aware that private home internet access in areas of poverty, you know, in large cities could be a huge factor for folks. You know, do you have the disposable income to own your own computer and pay for that internet access? But generally speaking, in the rural parts of the state of Virginia and other states as well, there's simply not the broadband infrastructure that exists for folks to access some of these health solutions. And so while, you know, the COVID pandemic brought about sweeping changes in how providers could, you know, provide care and maybe, you know, check in with folks, or even, you know, bring an addiction, you know, recovery program online and a support group online. If a person is living in a part of the state that they don't necessarily have reliable broadband and at the speed that is necessary, if you will, to be able to utilize video, you know, that's a real challenge. And I think, you know, that is something that is currently being grappled with at, you know, levels above me at the federal level in terms of making sure that broadband is more accessible to folks. The other thing that I think about too, you know, and that's at the systems level, that I think about too, and previously I worked in the health and housing intersection is, even if, because during the pandemic, the federal government incentivized, internet providers to provide internet at a reasonable cost and even subsidized, that taking off the burden of cost to have internet access. But often what happens, what we found for folks was that the speed of the internet that was being covered or paid for, that the internet providers were willing to provide, again, wasn't fast enough to be able to support not just video access, but the ability to interact, to do homework online. And that's a huge problem and creates the inequities that we're here, to discuss about. So those are just some of the barriers. And surely, as I've indicated, it's going to take more than a public health department. Obviously, we can be champions of and bring these issues up like I'm bringing up here today, but clearly it takes other entities and other industries to make sure that we have, eliminate these barriers and make, access to technology more equitable to folks.
Yeah, and I think that's a really great segue into my next question, and that's verse 3. So innovative technology has been discussed here today, and some of the barriers to using that innovative technology. How is the REEN Foundation addressing some of these challenges and looking forward on how we actually utilize technology to the best ability?
Yeah, thank you, Carrie. So I will just start at a very broad level and then get very specific. So at the broadest level, so from a care perspective, I look at it from 3 dimensions. One is awareness to seek care. Second is actually seeking care. And then the third is adhering to the advice after they receive care, right? So when most of the focus is equity in care, we're really talking about access. It is a big problem, and that's where majority of the funding, large institutions, everybody is focusing on. What we are trying to do at REEN Foundation is to focus on the other 2 parts of it, the awareness aspect of it and the adherence aspect of it, right? So now let me get a little bit more specific. So awareness, for example, and this is what Dr. Janusz and Becky also alluded to, is there can be so many YouTube channels, there could be so many websites that there's plenty of information, right? But as a human, I want answer to the question I have. I don't want to go research, find out, right? So we want to make it very easy for them to, if they feel like typing a question, speaking a question in their own language, right? They just open the app that majority of the world, I know it's not very popular in the US, WhatsApp is one app that 80% of the world uses, right? And I'm taking WhatsApp as an example. It could be any conversational thing, right? So they just open that and say, they just utter their question and they get their answer, right? So composing the information that exists is within this group. So the science-based organizations that understand the science, making it extremely easy for those organizations to make that information available, and awareness becoming very easy for people to consume that. Right? That's one aspect of it. The second aspect of it from an adherence perspective is I have been given an advice to take medication X, right? And one of the things that I learned from Dr. Sutter, in this, as we are preparing for this, is the executive function is one of the biggest area that is impacted, which means that people don't remember what they're supposed to do. So giving them a very timely reminder so that we can improve their adherence of taking medications, right? And keeping them away from getting re-impacted, right? So that's the adherence part of it. So what we have done in that space is we looked at, there are 6 areas in general, irrespective of the health condition, whether it is the substance use or otherwise, right? The 6 areas are medication management, like I told you, the symptoms tracking. So they, like, for example, they may be feeling very anxious. That's a symptom, like we touched upon, right? The vitals management. So if their heart rate is going up, it means that they're getting anxious, right? So we talked about medication, symptoms, vitals, and then nutrition management. And one of the things is that we know from science is that a magnesium enriched diet will keep a better sane state of mind. So recommending to them that these are the kinds of food, they may not know that, like, what are these foods, and giving them that answer or recommending those foods. Physical health management, as in just being able to take a walk or doing some very simple exercises to control their anxiety. And the mental health management, like doing mindfulness and meditation. So these are 6 areas. What we have successfully, we have successfully talked to other public health settings, whether it is maternal and child health, substance abuse, hypertension, other cardiovascular, all of them come down to these 6 areas. So our goal is to take the science that, like George Mason MAP clinic and that provides. And then again, this is a perfect setting. Like what Christina described, find some new young talent that will convert that science without a whole lot of knowledge of technology and apply it in a community, right?
Yeah.
So we are applying our knowledge, learning, and helping the community at the same time. We have a platform that is already there. They did not know about technology. Our goal is, yes, technology is important, but that is for someone else. Neither the providers are making something available, science available, nor the patients using should bother about technology at all. It should be done for them without technology, right? So our job is to really take care of technology in that sense, is not expose that technology. And one of the beauties in the new world setting is that we had to choose between personalization and scale. So if you went hyper personalization, you had to compromise on scale, right? But that is not true anymore. With what Dr. Anush just talked about, how can we may not be able to employ hundreds of thousands of people, but we can train a machine knowledgeable enough that would work 24/7 without getting tired, right? And I can train that machine to very specific conditions that I have, right? Similarly, even in technologies, cloud technologies and stuff, we can throw as much compute as we want, as much storage and network as we want. I mean, of course, money is a concern, but at least we're able to, bring that to bear. And, like companies like Amazon Web Services, through their health equity initiative, have funded us to be able to bring such a technology for public health and for larger population. So we want to bring the innovations in technology, and also, we touched about the concern for privacy, right? So what we have built is already HIPAA compliant, right? So which means, we have proper checks and balances in terms of how you tell us to use your data, how you use it. For example, when we talked about that geolocation stuff, right? So one of the examples where, when we were helping with finding COVID vaccination centers, and in the US, it's probably not a big problem, but if you think about countries like India and Africa, the population and the density is so high, but everybody knew how to just drop a pin on their WhatsApp. And if they dropped a pin on the WhatsApp, it will lead them to here. This is the path you take, go to the vaccination center. We can reverse that now to the extent that the individual allows us to track their location. We can tell them, that's just like literally hours of at most days of work to enable that for them. If they give us a thumbs up, and we know which areas are sensitive areas. That's what we can, gather from the science like Sandra was talking about. If the government knows what are the sensitive areas, if we know these two pieces of information, we can enable that service like almost instantly. We don't have to have anybody else struggling to build that service. So majority of the time, it goes into all the non-functional aspects of things: reliability, security, all the illities are taken care. We bring science and people together and start providing service and training people in the process. So that's our goal.
I
Sorry,
appreciate
long
it.
answer.
No, I think that's fantastic. And I think, I think it's important for us to highlight with the substance use and opioid use disorder epidemic that we have in place now, which very frankly was overshadowed by the COVID-19 pandemic. We have to work together. We have, from health and technology standpoint, have to all work together to create new innovative solutions to this, which we've discussed here today. And in doing that, we may see our way out of this epidemic, but there will be another. And so the lessons learned and how we care for this population will be translated for many, many years to come. And so what I'd like to ask is that, Christina, if you don't mind putting in the chat how anyone in our audience would get interested in the AmeriCorps or are interested in the AmeriCorps program, how they could get involved. And then I would really like to propose that we have the opportunity to explore this in another webinar series to be able to look at more detailed and have a robust conversation about some of the more details of the solutions. But what we do know is that it will take a village, and it's not siloed in health and it's not siloed in technology. The marriage between the two is very important. We have about 7 minutes left in this webinar, so I'd like to open it up for questions from the audience and see if there's any questions. And then I'd like to give our panel an opportunity to just say some final statements before we end today. So if you want to pop in the chat, or Uma, if you want to open the microphone to any questions, we'll give it about 3 minutes of questions. If none come through, we'll just have closing remarks from our amazing panelists today.
Yeah, we'll wait for a minute.
Mm-hmm. While we're waiting, why don't we go ahead and I can stop the final comments should any questions come through. So, Dr. Yanush, any final thoughts on opioid use and substance use disorders of population and how we move forward? Dr. Yanush?
Well, find out what people need and build right technology for it. And
I
again,
agree.
lots of things can be automated, and I believe if things can be automated, they should, at least to a large extent. And we know how to do it. We just need to know exactly what is actually needed by the specific population.
Great. And Dr. Sutter?
Yeah, I think that I just want to compliment what he says is that we're not building it for people, but we're building it with people, and we're using the data that comes from them in order to get to those really needed solutions. I think that those of us that are on the ground and doing the work can anticipate what we will see in the big data sets, but we really want to get the right data into there prior to us seeing it at a large scale. So I think we're in a next generation of what we can do. But again, I just always want to make sure that we're being responsive to the needs of those that we're serving.
Thank you. And Sandra?
Yeah, I would just second that and share that, I think making sure that data collection and analyzation, there's ways to make that more participatory with communities when folks are creating these solutions. And so there's entities like an organization called Health Leads that they've created like a data and equity framework that's available as a resource. So people who are trying to do this work don't have to start from scratch.
Perfect. And Christina?
Yes, thank you for including me. This was so interesting and informative. I just want to encourage anyone who is interested in either becoming a public health leader in the future or engaging public health leaders to please check out Public Health AmeriCorps. And I look forward to hearing about the partnership between Public Health AmeriCorps and George Mason.
And last but finally not least, any final closing comments? Sorry.
Thank you for really, organizing this webinar. But I remember one statement after I demonstrated the hypertension cardiovascular part of our platform. Both Dr. Sutter and Carrie, they said, "Sri, I don't think you know what you have in your pocket." And I was so excited to hear that. But what I certainly did not know is that we can bring a group together where I see that all aspects are here. There is science, there is artificial intelligence, there is the State Department, and there is an agency focused in community. I think we have everything here to just focus and get something done. And if we can bring along the students and create that next generation, oh my God, that is dream come true for me.
Well, I couldn't have said it better. And I really just want to thank you all for joining us today. And especially with a special thanks to our panelists today who have really, I think, explored substance and opioid use disorder really in detail. And hopefully out of this, we'll have some bright ideas and ways that we can continue to use technology and data to support this really important kind of population. So again, thank you everybody for joining us and look forward to the next webinar series.
Awesome. Thank you.
Thank you. Thank you so much.
Bye-bye.